right. So I'm representing we have the EHR data. What are the next data steps for research in the ICU? And so the way that we approached it is we started with our impact effort matrix. Again, the goal being the least effort and the highest impact is what should be targeted first, and then going from there. And as you can see, we have kind of a curved spread. We don't have much in the high effort, low impact, which is good because that's not where you want things. So it started here and kind of went to the batten for the fences. But we had a really good spread of different data ideas. So we talked about everything from collecting social media data to predict hospital surges to longitudinal data looking at long-term patient outcomes. We talked about using census tract data to collect social and environmental determinants of health, accessing biorepository metadata that's already there but we don't have access to. Talked about using kind of household living and functional status surveys long-term. And then over here at the kind of high effort, high impact, we have imaging data, genomic and biobank data, continuous waveform data, mostly those things. And then we all got to vote on which ones we thought were the most important, and this is what it came out to. So starting at the number one most important that we all voted on was physiological waveform data. That's on our continuous monitors, on our ventilators, to measure things like heart rate variability and things like that. That would be high effort. It's all the way over here in the corner, but everyone thought it was important. So high effort, but also really high impact. Number two is imaging data, which is here. We thought if we could get the written reports and the images for radiologic tests, echoes, things like that, there's a lot of good information and good research we could do with those. Number three was the longitudinal outcome. So, for example, if we could look at school performance before a sepsis admission and afterwards, or TBI, things like that, then we would have better data to evaluate long-term outcomes for our most critical ICU patients. Number four was our biobank genomic data that is being stored in lots of difficult to reach places and difficult to reach formats. But if we could find a way to get access to that and bring it in and harmonize it, that would be fantastic. Five was the census tract child opportunity index that is starting to be collected using kind of geocoding data from zip code, census tract, block group data that looks at environmental factors like pollution levels, household income, life expectancy, all those kinds of things. And that one actually we thought was pretty low effort because a lot of systems are doing that, like Phys is starting to track that regularly. And so if we could get that, that would be really helpful for, again, diversity, equity, and inclusion type studies and research. Number six, well, I actually didn't mention this one, but we talked about data regarding the unit. So how many nurses are on staff, what the experience level of the nurses and the respiratory therapists are. This is data that's not really being well captured in the EHR, but if we could get a sense of, on a given day, how many nurses are there, how many patients are there, what the acuity of the patients are, what the nursing ratio per patient is, respiratory therapist ratio per patient is, and then look at outcomes. Do we have greater delays in medication administration? Do we have increased rates of CLABSIs or CAUTIs, things like that? We didn't think it would be a lot of effort to get that, but potentially could have some meaningful impact with hospital administration. And then the last one, number seven, the research metadata, which again we have already. It's already collected and stored, but it's just not very accessible. So if we could find a good way to harmonize and increase our access to that, then it would be a big impact potentially in a short amount of time. I think that's a pretty comprehensive summary. Anyone else from the group have anything that they wanted to add?
I think some of our other discussion around the log data was the idea of matching provider experience and skills to patient acuity and severity as well, kind of looking at that match and how that impacts outcomes.
All right. Thoughts, questions?
Did you have a spring point on the learning management system? It kind of gets to what you were just mentioning, but it seems like that would be a relative, it might be difficult, but it exists, and sort of just taking what's there could be linked without a lot of effort. Making it really meaningful and important would take a lot of effort. Learning management system. So, is your basic life support PALS, what additional training, sort of the credentialing information that the hospital keeps and links could be a data source. When were you last trained on CRT, et cetera?
One topic that came out of that is also, and we discussed this in the advanced education breakout yesterday, is how do we do those things, but also keep sort of keep it in a positive, constructive way, psychologically safe for the learners, for maintenance of certification in a way that's not sort of punitive. Oh, we're not going to put you in this area of the unit because you're not qualified to take care of the sick kids. And there's a little bit of a vicious cycle there of also having experience taking care of sick kids. So it's a dangerous territory. I think when we start doing this operational type research of matching competency to level of skills, that I don't know. I mean, you're obviously a super expert there, right? But
no, I agree with you. The perception of that, but think of how easy it would be for your hospital to joint commission credential if you had that you could just pull right in.
Yeah. Yeah, but I think just the idea was like, how can we make a system that is constructive and not punitive or skewed because of that, historic competency and not become a vicious cycle of, yeah.
I don't think this will reach.
This may be tangential to the question, but when we talk about the data enhancement and how to do this, thinking about what was touched on a couple of times of how do you identify the patients with sepsis in the cohort? How do you identify ARDS? How do you identify patients who've had a cardiac arrest, et cetera? That is not going to necessarily come from the raw EHR data, but is going to need some effort. And I don't know if it's almost a secondary data source that comes from the primary data source, but if that gets added to that too.
So something like that was on our temporary list, but for our initial list, but it didn't get any votes.
I vote for it. I don't.
I see it as the one that put it up on the list. No, I completely agree. Like, I think we run a series. Yeah. So we were only allowed to vote for two things, and it was my third vote. But yeah, so I personally, and I think there's some truth to this, or a fair amount of truth to this, like I worry about using the billing data and even like the problem list data as like diagnoses that are real, because I think some of them are and some of them aren't. And I think we're going to run the risk of misidentifying patients. So
The one thing I would add on that, if Alon gave it as a lot in this realm, is using what's called a computational phenotype. So taking a lot of EHR data from medications and things like that all together rather than just an ICD code.
That requires building that and validating
And-
that against chart data. And I think that's a lot of work, but it needs to be done.
And just to say, I can guarantee you the billing diagnoses and problem lists are horribly wrong for most of the things we care about.
You already brought it up. I was going to basically comment on the computational phenotype thing. I think, to me, that is probably the biggest growth opportunity that this collaborative has, is the potential for, we talk about, does this kid have sepsis or not? And like it's some kind of binary thing of either it's true or it's not true, and that's not the case. There's like shades of sepsis. And, this guy had the fever, but he didn't have, he didn't require a fluid bolus, or he didn't get started on pressors, where another kid didn't have fever, but ended up getting 80 per kilo and is on triple pressors at the end of the day. So I think, finding ways to, put these kids into, this is a category 1 or a category 2 of important things that have happened in their trajectory, and being able to say, I want to find out of the kids that just received fluid boluses, what did they look like, and how do I know that this kid that I'm dealing with right now is a fluid bolus kid and not going to be the kid that got, 3 fluid boluses, 4 transfusions, triple pressors by the end of the day.
So when I'm in round one, the resident do not tell me, oh, this patient is septoid. I want them to tell me, this patient is 37% sepsis, and they should get 6.5 ml of PRBCs.
I always look at lists like this and I wonder, like, I feel like at least some of this stuff is already at least partially in the EHR. It's just a question of whether and how we can access it. I'm pretty sure that for legal reasons, they keep track of which user entered every data element. That's not going to give you the component of their skill level or experience, but we could probably pull that. And the census tracts, if you have a full address, obviously you can map those to the census tracts. Even the waveforms, like the waveform itself might be hard, but I think Philips spits out every 5 seconds, or even I think possibly more, depending. I don't know much about the Philips, but so we could get that in a slightly different way. It already feeds into our Cerner, although I don't think it's stored long term on our Cerner. So some of it's hard, but some of it's maybe less hard than we think it might be.
So I think the discussion about the patient level characteristics are important, but I think it was 4th or 5th or 6th on your list was the unit level characteristics of the staff and the competencies. And that may be as important as the patient level, right? You may, if you walk into a unit with completely inexperienced staff, children may be more at risk than if you have a staff that's been there for 20 years and very experienced. And I think we've all lived that you look around the unit and you see who nurses are and you feel better or worse depending on the day or night. I don't think we can, there's no automated way to catch that. That's got to be manual. But I don't think it's something that we can overlook.
Who's the attending you're signing out to?
I agree. Nurses sign their notes. And so that's how you keep track of who's taking care of the patient. And you could compute continuity of care and look at the impact of continuity of care on outcomes. You can also, we do have data that shows if 20% of your workforce is less than 3 years of clinical experience, you have different outcomes. So we have that data, at least, in press. And there was a recent paper that looked at the team effect of people working together. And there was a mortality benefit when you had the same team working together compared to not having them work together. And, we are doing a better job matching nursing expertise to patients in what we consider to be minimum competencies at CHOP. And then we created unit profiles so we know what kind of patients are cared for throughout the institution, and we match that to nursing profiles. And now we can better match patients to nurses to outcomes and show the return on investment of making sure that you have a talented workforce taking care of a patient population. And we're also, the return on investment there as well is not training the entire workforce to do everything, only when it's necessary by that patient population based on data. So it's possible.
Yeah, Martha, I would agree with you. The one thing that is extremely difficult is how do you know not just who signed that note or who was there as the primary nurse for that particular patient, but the team. Because in the evening time, a lot of things get accomplished with fewer people and actually have more efficiency. Because what happens is there's fewer activities taking place. And as soon as a new admission comes in there, there's a movement of others within the unit to assist in that process. And I think this is one thing that we've had concerns about at the physician level, looking at peer evaluations for years of just keeping record of who the patient's assigned to, because that's, as a team, it's really dependent on how the team's functioning, which kind of goes to what you were already saying. I'm not sure we have a great way of capturing that right now. I don't know. Maybe somebody's got it.
There are features that you can tease out. There are breadcrumbs in the EHR that can speak to assignment or attribution of teams and roles. And folks who've used EHR audit logs can have some familiarity with that. What I was going to quickly suggest is if you're looking at these types of outcomes that are workforce related, you might also need to incorporate things like safety events that are occurring with these patients. Simple things like retract and reorder for the wrong medication would be an easy safety event that gets attributed to a particular provider, which is caught by another provider. Those are also sort of features or outcomes that might be important.
Excellent. I'll use that as a transition. Adam, since you're already talking, I'll have you present, or your group. Adam, did you assign a spokesperson for your group? Yes. Stephanie, excellent. Thank you.